it's
Okay.
you're staying. Okay. I'm not sure what. Okay, perfect. All right. So I would like to welcome everybody to the Scoliosis and Spine online learning. Good morning, good afternoon, good evening to everyone joining us from around the world. Over the past decade, we have built a global learning community and an extensive webinar library dedicated to scoliosis and spinal disorders. We truly believe that learning never stops and that scoliosis education should have no limits, no obstacles, or borders around the world. We believe reaching and teaching and uniting professionals to improve care. Today, SSR participants from over 100 countries joining, and each month at our free webinar series, we have professionals joining in from 30 to 40 countries in average, and all eager to learn from leading experts in scoliosis and spine care. Our monthly webinars are available for everybody. We also offer certification courses. It's very popular. The Leon Method course, it's 100% online, where students from 5 continents join Dr. Jean-Claude Mauroy and myself, an interactive monthly session learning about scoliosis physiotherapy and the ART brace. Our international Schroth certification program includes online and practical components with the fundamental course available now in 6 languages through our SSR library. In-person courses, which we deliver over 4 continents now, by our experienced education team led by Dr. Hagit Berdishevsky and myself. I was mentored and appointed as a Schroth teacher by Castelein Schroth, and we are committed to continue her legacy through evidence-based high-level education of professionals. It's available for PTs and PTAs, and we welcome observing medical doctors and orthotists. Our video library is open 24/7. We have over 160 presentations there recorded, and we hope that you subscribe and you have immediate access for over 50 lectures from our global presenters. As we complete our decade of global education, we hope that scoliosis care improves in every region of the globe and that no child suffers due to lack of knowledge and inconsistent treatment. Even here in Ottawa, Canada, no clinics, no hospitals treat scoliosis the same way despite of following SRS and SOSOD guidelines. And it's very important to have these discussions, and happy to share with you my latest publication on a Canadian situation if it helps you in your community. Today, we are exploring a very important topic, the gray zone. When to brace, how to brace, when brace or not to brace, that's the question. And the gray zones sparks different approaches across the continent. Today, we begin with the perspective from our European experts, and in a future webinars, we will explore North America, South America, Asia, and beyond. Let's begin with this important conversation with introducing our today's panelist, Dr. Ahmet Alanay, who is from Turkey, an internationally recognized spine surgeon and leader in spinal deformity management. Thank you, Dr. Alanay, to be here with us. Dr. Jean-Claude Mauroy, we next welcoming you as our regular presenter, and his work of decades of conservative scoliosis care has influenced bracing and physiotherapy worldwide. Thank you for being here. And Rene Castelein, we're honored to have you here, a leader in scoliosis research, biomechanics, and innovation. And thank you for joining us for this discussion. And finally, Dr. Fabio Zaina, a specialist in physiotherapy, rehabilitation medicine, and a strong voice in evidence-based conservative care of all ages. We appreciate your participation. Dr. Hagit Berdishevsky will do the introduction.
Thank you, everyone, for joining us for our great seminars and webinars. It is my great pleasure to introduce Professor Ahmet Alanay, an internationally recognized leader in the spinal deformity surgery. Dr. Alanay graduated from Ankara University Faculty of Medicine and completed his orthopedic residency at Hacettepe University. Over the course of his distinguished academic career, he rose from assistant professor to full professor and further refined his expertise through a spinal deformities fellowship at the University of Kansas Medical Center, as well as serving as a visiting professor at the UCLA. In 2013, he established the Comprehensive Spine Center at Acıbadem Maslak Hospital, where he currently serves as medical director. Each year, he and his team manage over 2,500 outpatients, perform approximately 200 surgeries, and contribute extensively to the scientific literature with more than 20 peer-reviewed publications annually. Professor Alanay is widely respected for pioneering vertebral body tethering surgery in Europe. He has served on the board of directors of the Scoliosis Research Society and was the 25th president of Eurospine. His leadership, innovation, and commitment to surgeon education have significantly shaped modern scoliosis care. Please join us in welcoming Professor Ahmet Alanay.
Thank you, Hagit. Thank you, Andrea. Also, thank you for the very kind invitation. Yeah, so my topic today will be discussing on the gray zone in growth modulation. And I will question actually whether we are measuring it correctly and from the right skeleton markers. And I will actually approach the problem from a surgeon's perspective, of course, actually from a perspective of growth modulation, which is important also both for vertebral body tethering surgery and also for bracing. And here are my disclosures and nothing related with this topic. So when we are doing fusion surgery, skeletal maturity assessment was actually relatively simple. So we were using Risser menarche chronological age, and most of the time that was enough for the fusion surgery. The gray zone in fusion surgery was not really about growth, it was about timing diffusion. But when we started performing vertebral body tethering, everything changed. Because as you know, in vertebral body tethering, we use the growth for a spontaneous correction or growth modulation of the existing curvature, scoliosis. And because VBT forced us to respect growth in a way fusion never did, suddenly the question was no longer whether the child is mature or not, but rather how much growth is left, where is that growth occurring, and most importantly, will that growth translate into modulation? Or do we have any growth left to provide modulation effect? Because that is the main thing for the vertebral body tethering and non-fusion scoliosis surgery. So that is where the gray zone became really very critical and a challenging period for decision making. And I think this is, again, for not only VBT, but for brace treatment as well, as we are using also the modulation for the brace treatment. So for decades, Risser guided us. It was simple, practical, reproducible, but Risser was a non-axial marker. It was an appendicular marker, and it reflected iliac apophysis ossification, and it did not directly tell us what the spine is doing. In fusion surgery, that did not matter much, but in growth modulation surgery, it matters a lot. Because Risser 4 does not mean trunk growth is over. And in VBT, vertebral body tethering, trunk growth is everything. We started seeing when we were using in the beginning of our VBT experience, the Risser sign, we have seen unexpected overcorrections, unexpected failures, different modulation patterns in patients with similar Risser scores. And we realized that Risser was not enough, especially in those patients in the gray zone. So then Sanders came in our practice, a simplified skeletal maturity staging derived from hand ossification. It was more comprehensive to predict the growth, and it correlated better with peak height velocity. It became extremely popular for VBT decision making. And yes, Sanders improved our predictions, as we have shown in our recent study. But even with Sanders, we saw surprises. And same Sanders stage, we have seen different curve behaviors, same growth, but different modulation. So the question became whether the appendicular skeletal maturity parameters were really reflecting spinal maturity. Or, in other words, are we measuring the wrong skeleton? We know from the Maglio studies that puberty is not a single peak. It's a combination of 3 micropeaks, actually. First peak, lower limbs. The second peak, trunk. And the third peak is the thorax. If we are using only appendicular markers, we may be correctly measuring the first peak, but we may be completely missing the trunk timing. And in vertebral body tethering, modulation depends on trunk growth, not the leg growth. So this conceptual shift was critical for us. So we asked ourselves, why are we not assessing the spine itself? And we have looked for a parameter which is showing the maturation as an axial skeletal marker. And then we found cervical vertebral maturation, CVM, which was widely being used by the orthodontists in the orthodontic literature. And they have shown that it correlated with growth, but it has never been evaluated in relation to spinal growth modulation. So we designed a prospective study comparing in vertebral body tethering patients the growth parameters, Risser, Sanders, Toki, and CVM, and looking at total height gain, leg length growth, and curve modulation after vertebral body tethering. And what we found was really very interesting. First of all, appendicular systems, Sanders and Toki, performed better for predicting the leg growth. That made sense. But when predicting the total height gain and trunk height gain, curve modulation after VBT, CVM performed as well or better than Sanders. So more importantly, as you can see in this figure, we observed both discordance and concordance between all the skeletal maturity markers. Trunk peak height velocity could occur before leg peak height velocity, simultaneously, or after leg peak height velocity, meaning that a patient could be Risser 4, Sanders 6, almost close to maturity, even post-menarcheal, but still having an axial growth potential. That is the gray zone for us for vertebral body tethering, and that is where decisions become critical. Look at this 14-year-old girl, 12 months post-monarchy, Risser 4, Sanders 6, Toki 7, but CVM 4. So CVM 4 means there is still a growth modulation, but Risser 4, Sanders 6, Toki 7, according to our previous beliefs, the patient would not modulate after the surgery. So we decided to get as much correction as possible by doing a vertebral body tethering. But as you can see, she demonstrated a significant modulation after VBT. So if we had trusted Risser alone, we might have denied her modulation surgery. This is not theoretical. This is, as you can see, a clinical reality. Another observation, and I should say this carefully, in our experience, lumbar curves seem to retain modulation potential longer than the thoracic curves. The lumbar spine may mature later, and this is not fully scientifically proven yet, as far as I know, but clinically we see it. Especially in the thoracolumbar and lumbar curves, we sometimes observe modulation, even what we thought was late maturity. So perhaps axial maturation is regional also. And perhaps we are stopping bracing or denying modulation surgery VBT too early in some lumbar curves. This connects directly to today's gray zone discussion. look at this patient who had a double major curve, and we did a bilateral VBT for this patient. And again, as the patient was Sender 7, Rister 4, we actually tried to get as much correction as possible. But as you can see by time, we had seen a great modulation effect in the lumbar spine. So the lumbar spine had a over correction, and this S-type shaped curve turned into a C-type at the end of the maturity. And this patient had a CVM4. Or this patient actually, I think, inspiring this webinar that I shared in LinkedIn, a patient, again, a Sender 7, we decided to start a bracing for this 36-degree magnitude of curve. And as you can see, with a great modulation in the thoracolumbar region, this patient ended up in 1 year, actually, correction both in the curve magnitude and also in the rotation of the curve. So what do we do in practice today? When considering modulation, whether brace or vertebral body tethering, we now assess Rister, Sanders, Toki, CVM, menarche, curve type, secondary sex characters, sitting versus leg growth, everything. But when axial and appendicular markers disagree, I trust CVM more for modulation decisions, because growth does not equal modulation and appendicular maturity does not equal spinal maturity. So now, as my last verse, I would like to leave you with a few questions. Starting with, is skeletal maturity a single event or a regional dynamic process? Are we over-relying on appendicular markers? Are we stopping bracing too early in some patients? Are we denying modulation surgery in the gray zone because we are measuring the wrong skeleton? And perhaps most importantly, is Rister still guiding us or misleading us? Thank you so much.
Thank you very much. You're certainly giving us more questions to think about, and we will definitely try to incorporate a lot more markers than just Riser and Sanders for our future assessment. We're going to move on to the next presenter, and Hagit is going to introduce Dr. Jean-Claude de Mauroy.
It is truly an honor to introduce Dr. Jean-Claude de Mauroy, whose career in scoliosis care spans more than 5 decades. Dr. de Mauroy began his journey at the renewed Centre de Massus, where as a medical student he worked alongside Dr. Stangara on infantile scoliosis. He went on to lead a 36-bed pediatric orthopedic department and has dedicated 55 years to treating patients with spinal deformities. In 1987, he founded the European Spine Center to continue caring for patients into adulthood, reflecting his lifelong commitment to continuity of care. A clinician and biomechanist, he has combined scientific rigor with practical innovation. He is president of the International Society of Spine Research and past president of SOSORT. He is also the co-inventor of the Art Brace, a modern evolution of the Lyon brace concept that has influenced conservative scoliosis treatment worldwide. Dr. de Mauroy's career bridges history, biomechanics, and modern conservative care. We are privileged to learn from his remarkable experience. And we are privileged to have you on our SSOL as a teacher and leader of the Lyon method. Please join us in welcoming Dr. Jean-Claude de Mauroy.
Thank you, Hagit, for this kind presentation. If it's possible, I will share my screen. The topic was all starts at Riser 5. And if we look at this picture, it comes from Di Meglio in France. You see that the growth of the spine here in green finished, but not in red the pulmonary system, the thoracic cage. So sometimes it's necessary to change the brace to wait for the end of growth of the thoracic cage. The second next problem is the bone mass. You see the end of growth here, 15 years for girls and 17 for boys, but the peak bone mass is at 23, 21, 23, and there is still a fragility of the vertebral body, and we see some scoliosis, some progression of scoliosis after research 5. So this is why we try to remove progressively the brace, and this is the work of Rene, very important to advise the patient to practice sport with axial impact, like jogging, running, dance. This type of activity increase the fixation through piezoelectric current in front of the vertebral body, and this increases the resistance of the cortical. So after 20 years, between 20 and 40 years, what succeed? It's not finished at 15 years when we remove the brace. There are three ways to follow this evolution. Anatomical way, we are at 20 years a maximal of tensegrity, sport activity of high level. Biomechanics, we have the maximum of amplitude on the spine, and neurology, we have the maximum function. Here we see the result of the lion treatment. Here you have till 20 years, we have 123 patients. All patients are included in a register, so the register is treated at the University of Chicago, and you see that the initial average of all cases, all treatment we do by brace included in this register, and 20 years after, we have a good stabilization of the curve. For the thoracic curve, 9% of improvement, and for the lumbar curve, we are better, 20% of improvement. So you see the curve with beginning of angulation, thoracic in blue, lumbar in yellow, and the average in red. Between 20 and 30 years, we have 30 patients, I think, complete with X-ray under plaster cast. This is very difficult because 30 years after they lose the X-ray at this time. So you see we have a stability for this patient between 20 and 30 years. This means that the usual instability at 45 years, probably when there is a good treatment during adolescence, we have not so much instability and 45 years. So there is a difference between natural history. We know per 35 degrees at the beginning, the progression is half degree every year. And we have some other statistic with other braces. All braces are not equivalent. Boston brace, there is a reduction, but less than Milwaukee. And for the Lion method with plaster cast, I think the difference is the plaster cast at the beginning or the full time. Olisa in Roma, quite the same as we have with a progression of 0.15 every year. What advice can we give to the patient when we see this evolution? We give usually the first advice is to avoid together flexion and rotation. This was all publication of Nakemson. At this time, it was possible to introduce a monitor to measure the pressure inside the disc. And with flexion and rotation, we have 500% more pressure at the disc level, like this, like lifting a weight of 20 kilos. It's exactly the same. So if we want to avoid this rotatory dislocation, it could be interesting to avoid flexion and rotation together. Yoga, Pilates, it's easy to avoid this type of motion. Second, to take something on the ground, not to bend the knee. Squat is not very good for scoliosis. Why? Because in this position, we have a tension between head and feet by the deep back line and also deep front line. And this tension increases the resistance of the spine. If we bend the knee, there is a diminution of this resistance of the spine. So this is the two advice we give to the patient at Research 5. Then usually we don't have an increase of progression with pregnancy, only with twins. When we see in the aspecting room this kind of device, probably it could be an increase of scoliosis. So 20 years with a good treatment during adolescence, quite no problem. Then begin between 40 and 60 sarcopenia. Sarcopenia is a characteristic of all person, even without scoliosis, but at 50 years. For scoliosis is at 40 years. At the biomechanical level, we have delordosis and retroversion. This is the risk. And neurologically, between 40 and 60, no great problem. So you see the sarcopenia, MRI at level L3, there is a great difference in the quality of muscles. Important to know that there is no secret to muscle growth, but the force generated by muscle fibers is the same if you realize active contraction or passive stretching. And important to understand that hypertrophy, we cannot increase the number of fibers because all the muscular fibers are at birth. And you can have hypertrophy both with heavy loads and lighter loads. For scoliosis, we choose lighter loads. The process is mechanotransduction. I don't insist on this. And you see, very important, you can have muscular hypertrophy, but not increase the number of muscular fiber. No second chance with muscles. And you see the motoneuron alpha. There is one motoneuron alpha for type 1 fibers in red and another motoneuron alpha for type 2 fibers. And this is, I think, very important. During during growth, you see that it remains the same number of fibers, but with sport activity, physiotherapy, you increase the mitochondrial and nuclei, so you can grow, the fiber can increase length. And without sport activity, you have the same number of fibers, but less energy, less mitochondria, and less nuclei. For adult, there is a problem because with sport activity, you maintain the number of fibers, the quality of energy, mitochondrial, and nuclei. But if there is no sport activity, you lose the muscle fibers, and there is no, like I said before, no second chance. At the biomechanical level, we have this mechanism, vicious mechanism with pelvic loss of lordosis, pelvic retroversion, pain, instability. And another advice is to avoid this retroversion, is to avoid abdominal and gluteus muscles. This is done with CrossFit, so it's to avoid, and better iliac muscle and quadriceps rectus femoris. You see a reduction of 8 and also loss of tensegrity. And you have at 45 years this instability. For physiotherapy, it's important to introduce resistance. We don't use a lot of resistance during growth. And here, for instance, the airplane exercise is against resistance. And also, we work in close kinetic chain at 90 degrees square, 90 degrees hip flexion to obtain a better stability, the same at this level. It's a second square, and the physiotherapist work in lordosis and ask for correction of the curve, opening the concavity. The first is to lengthen and strengthen the rectus femoris. So you see the motion of lengthening, and then you ask the patient to strengthen the rectus femoris. Between 60 and 70 years, we have osteopenia, not only sarcopenia, osteopenia. We have high kyphosis due to this osteopenia, and we begin at the neurological level with vestibular and proprioceptive signal defects. There is some difference with osteopenia. Men, we have a thinning of the trabeculae. Women, a decrease in number of trabeculae. This is why the fracture level is at 65 for women and 85 for men. And you see this high thoracic curve. And at the level of neurological level, it's important for golf, for instance, monostance during sport activity. This stimulates the neurological system, and we lose the proprioception at the feet level, so we use the haptic proprioception with the stick to work with the grip. And this high kyphosis, the patient need hip flexion to maintain the occipital axis. So physiotherapy at this moment, the concavity, we use like Schrott, the hanging position for decoaptation. And between 70 and 80, we have a cognitive defect. And at this moment, it's a double task. Double task is very easy. We see some imbalance. So you can count backward from 100. And with the Lion method, we use the level stick. So during the exercise, the patient controls the horizontality. It's a way to treat this cognitive approach. So you see the level stick at this level together with geometrical distortion. So I finish with this after 50, 55, we lose sometimes totally. And it was, I work in Palermo, in Sicilia, and there is a mosaic with only miracle with spine, is the Gospel of Saint Luke. And I hope that with braces, with good physiotherapy, we can also realize some miracles for our patients. Thank you for attention.
Thank you very much for Dr. Jean-Claude for this lifelong learning of all the obstacles we have to face during our scoliosis and spinal journey. It's very educational. We have a lot of questions about your presentation, but I can encourage our attendees to attend the Leo Method course. So we cannot really answer details of your questions, so attend the Leo Method course for more learning. I'm going to pass the microphone over to Huggy to introduce our next panelist.
It is a pleasure to introduce Professor Rene Castelein, Professor of Orthopedic Surgery and Pediatric Orthopedics at University Medical Center, Utrecht. Throughout his academic career, Professor Castelein has focused on complex spine care, biomechanics, and the etiology and pathogenesis of idiopathic scoliosis. His work has advanced both surgical and non-surgical treatment strategies. He is co-innovator of two patented dynamic spinal implant systems, the spring distraction system and the double spring reduction, and co-founder of Cresco Spine, working to bring innovative scoliosis solutions to market. He also co-founded the Dutch Scoliosis Center for Multidisciplinary Conservative Treatment. Professor Castelein has published approximately 300 peer-reviewed papers, supervised over 30 PhD candidates, and co-edited the book Advance in Idiopathic Scoliosis Etiology. He currently serves as editor-in-chief of Spine Deformity, the official journal of the Scoliosis Research Society, and has received numerous international honors, including the Jean Dubosset Medal. We are honored to have such a distinguished leader in scoliosis research and innovation with us today. I'll welcome Dr. Castelein.
Thank you, Hagit. And if you can share your screen, Rene.
Well, thank you very much, Hagit, for your very kind introduction. And thank you, Andre, also for organizing this. It's a wonderful symposium, and certainly with a lot of discussion coming up, I'm absolutely sure. So I gave my talk the title, Why Does Scoliosis Progress After Skeletal Maturity? You could also say, does it progress? But I think many people, maybe all people, agree that it can still progress. I don't think there's much discussion to it. The other title I thought of would be, can adult spine deformity be treated conservatively? Because there's debate about that too. There's papers in the literature that say that the only treatment for degenerative scoliosis would be surgical. I don't agree with that at all. I think that's a phase discussion. Once you see a spine or a patient with a spine that is totally dislocated all over the place from C7 down to the pelvis, then probably surgery is the only thing. But I think we need to invest much more in understanding the pathomechanism of adult scoliosis, because obviously this doesn't start with a rotatory subluxation. It starts with a minor event, usually at the lumbar level, L2, L3, where at that stage much more would be possible than eventually after waiting for the full picture to appear, where you have to do a fusion from high thoracic down to the pelvis. So I'm trying to comprehend the principles behind the things we're puzzled about and we're trying to treat. So these are my disclosures. They have nothing to do with this presentation. So I just mentioned some dilemmas in adolescent idiopathic scoliosis. What is skeletal maturity? And Ahmet already gave a wonderful presentation on the discrepancies between our usual methods of determining skeletal maturity. And they certainly have a lot to do with why, when we think that the spine has become stable, still progression occurs. In adult spine deformity or degenerative scoliosis, the question is, do growth modifying strategies, and I include VBT in this, because I think, and Ahmet pointed that out also, that the principles for VBT and for conservative corrective treatment are very similar. I just picked out one paper that demonstrates that after brace weaning, and in this paper from Hong Kong, brace weaning was done according to the SOSORT and AIS criteria. So probably the way many of us would do that. But then you still see that after weaning half a year later, the curves have progressed in the majority, and 1 year later, and even 2 years later, you still get progression. Whether that is clinically important is another question, but it must make us think of how we come to our decisions. And here you can read that, for me, it's behind the gallery. So here you can read that the curve progressed more than 5 degrees after completed brace treatment, and I think the criteria were pretty adequate in 43.5% of the patients. So the next question is, and that has to do with all this discussion of today, what are we trying to treat? And I think it's important to go into this to understand what we're trying to do, and then by understanding it better, maybe come to better paradigms and better flow charts as how to make our decisions. Is it bone growth that we need to treat, or is it soft tissues? And this is very much a debate, and this is not hard science, but I'll give you my opinion. I'll give you the direction that we are working on at this point. Here you see an example of a patient with an adolescent idiopathic scoliosis before correction, before treatment. During correction, you see a slight difference. Cannot deny that. It's not a major difference, but it has changed. It has probably improved. And what has happened here? Has the bone now really improved? Well, certainly not, because the MRI was taken on the same day. It was taken before the brace was applied and right after the brace was applied. So nothing has changed to the bone, obviously. That would take much longer. But what you see, and I think this is very important, and it shows wonderfully here, is that you have changed the shape of the apical disc. And not only the apical disc, but all the discs around the apex do the same kind of thing. So in my mind, scoliosis treatment, especially conservative treatment, is regenerative medicine of the intervertebral disc. And here you see a animal experiment that we did where we induced the scoliosis. This is a different spine than human because you see a true growth plate. Humans don't have that. They have more of an apophysis than an epiphysis, but doesn't make too much difference. The most important thing you see here is that the disc shape has changed, and the nucleus pulposus has shifted to the convexity of the curve. This is nothing new. This was described by anatomists already more than 100 years ago, but this is a modern way of saying something that some people have known for a long time. The other thing you can see on the MRI scan is that that nucleus was shifted to the side. It tries to come back to the midline, but it doesn't really make it. Although the disc looks pretty parallel, or the end plates look parallel, the nucleus remains a little bit out of the center where it basically should be. And this is where I come back to that animal experiment where you see that that area where that disc came from has been filled up with connective tissue. What it is, we're not sure. It's probably something that has to do with the annulus fibrosus. But anyway, that shows that it's going to be very difficult for that disc to move back. It's going to take a lot of force to release this contracture, because that's what it is. It's a contracture on the concavity, and to allow room for that nucleus pulposus to shift back. Now, we have to realize something, and this can be debated too, but I'm convinced that this is true, and we've published quite a bit on that also. The human spine always, throughout life, wants to go into rotation. Rotation is not an unusual phenomenon for the human spine. If this human spine would not have stabilizers, it would, in almost all cases, end up in a scoliosis anyway. So due to our human spinal biomechanics, which is totally different from other spinal biomechanics, not because we are bipedal, because many species are bipedal, but the way we are bipedal is very different. So the human spine always, and I put it bluntly here, black or white, but young and old, all these spines want to go into scoliosis. So the question should not be why does scoliosis at any age progress, but what prevents scoliosis from progressing? And which structure normally stabilizes the spine? Well, you can see that here. That is the intact disc. And the disc, in my mind, is much less of a shock absorber, but it's a ligament that stabilizes the spine. And here you see that that ligament has become insufficient, and that vertebra has dislocated away from the vertebra below. And if you look at the picture on the AP X-ray, you see that it's not only a shift, it's also rotation. So this spine has been more or less straight for a long time until the stabilizer was worn out, the disc. It starts to be unstable and it shifts, but more importantly, it goes into rotation. Very important to realize is that when you have a healthy disc, your torsional stiffness, we call that in a study we did, we called it 100%. That's the healthy segment. Then once you get disc degeneration, a couple of things happen over time, but it goes to very unstable, less than 50 or almost, no, 54% of the original value. When the height of the segment has decreased, so your disc has collapsed. But then after that, there's always a stage where you get restabilization. You get ankylosis of the disc. It doesn't move much anymore. But obviously, it would be much better to have a non-moving disc in a straight spine than in this kind of a situation. And that's where our efforts at treatment should be directed. So the intervertebral disc for me is the target tissue. And we do a lot of studies right now on the intervertebral disc. The problem is that we know much, much more about the aging disc and not so much about the maturing disc. The aging disc, both biomechanically and histologically, and as far as imaging is concerned, has been described very well. But the developing disc, the maturing disc, is not very well known. We don't know for sure what a girl 8 years old, her disc properties are compared to when that same girl is 14 years old. So we did a study. Lorenzo Costa was the first author. He was a PhD student of mine, finished about 2 or 3 years ago. And we looked at the insertion, and now we're getting close to Ahmet Alanay's topic. We looked at the insertion of the disc, and that is called the ring apophysis. You cannot see that very well on a regular X-ray. So we looked at a database, an existing database of CT scans, where you could really very well, over different ages, evaluate the ossification. Here's no ossification. Here you see some ossification. These are the fibers of the disc that attach to the bone ultimately. In the beginning, it's cartilage. Now it's becoming a little bit of bone. Here it starts to fuse, and here it is totally fused. Of course, you could not do any study with CTs. We have never taken one CT scan for a study purpose. We've always used existing databases, but fortunately with bone MRI, and I'm a bit involved in the development of bone MRI. Bone MRI is a technique where with artificial intelligence, you create CT-like pictures of MRI scans. And you can see on the bone MRI, this structure pretty well. And you can see it, if you go back to the original MRI, you can see it also. So there are ways to visualize this without CT scan, without radiation. Now, this is a bit of a busy slide, and I'll go through it in a very easy way, because the only thing you have to realize is that how darker it gets, the more mature the disc attachment, so the ring apophysis is. So this is very mature, end stage where the ring apophysis is fused to the bone. The lighter it gets, the less mature the ring apophysis is. Right here, it's very immature. So over time, when you grow older, it gets more mature. What Ahmet just asked was, are there different levels of maturation in the spine? Well, there are. And you can see here at the top, when these are already more mature, the ones in the mid-thoracic area, and once you get a little bit older, fewer ones in the mid-thoracic area, but also towards the lumbar area, are less mature than the ones higher up or lower down. So around the thoracolumbar area, the maturation is less advanced than in the upper thoracic or in the lower lumbar spine. Even though someone is RISR 3, which says something about the whole spine, it is something that depends on the different levels. So this is the normal population, CT database of normal patients, CT for trauma or pulmonary disease. This is a CT database, CT taken for navigation purposes, of scoliosis patients. And what you see immediately is that all these disc levels are less mature than in the normal population. So it seems to look, and this is only 2 studies that we did, but it looks to us a bit like the maturation of the disc in scoliosis goes slower. So that sounds like a mismatch between already mature loads. Someone has really grown pretty much, has gained weight, has gained length, but the disc is not yet so mature, and an immature disc is not so able to stabilize the spine. And this is where that is summarized. If you go through your growth spurt, you don't only have changes in hormone levels, these have been studied a lot, but you also gain weight. And if you do that while your spine is still not so mature, then the weight may become excessive. That is not unusual. We know that from Osgood Schlatter in the knee and from the anterior inferior iliac spine, where the rectus works too hard, or the medial epicondyle of the humerus. There are many other syndromes, you might call it, where the force that is applied to an attachment is already much bigger than what the attachment can hold. And here you see the same mechanism. This spine was normal until a certain age, when the disc wear out and they go into this beautiful de novo scoliosis. So the mechanical properties of the disc in my mind determine the spine's power to resist that always present force that wants to induce rotation. And there are two periods in life where that can happen: in puberty, when the loads increase suddenly and the disc may not be ready for it. And once you get much older, the loads remain more or less the same, but the disc becomes much less stable. So the driver, that ever-present rotation-inducing force, and the protection is the well-functioning and stable disc. So we don't need all these remote, as Ahmet also called, and I agree with him, criteria. Eventually, we should have something that is much more related to the spine. It is only stable when that disc has become stable. So in my mind, adolescent idiopathic scoliosis and adult spinal deformity are two ends of the same spectrum. The vulnerable disc must be protected. The shape of the disc must be normalized. So that means, in my mind, early treatment is a very good idea. If you know that a patient is going to have a progressive scoliosis, that's another debate, another topic. When do we know that? But once you, with your clinical experience, think, hey, this is going to be a progressive curve, there's no reason to wait until 25 degrees Cobb angle or progression from 25 to 30. You're basically missing a window of opportunity. And risk of 4 or 5 or center 7, 8 is not the end of spinal growth. And we need spine-specific radiation-free indicators of disc stability. Thank you.
Thank you very much for this very detailed discussion and presentation on the disc. It's extremely eye-opening for us, and we hope to hear more from you as your research progressing. Now we examine bones, muscles, and disc, and we're gonna go into a different age group. And I'll let Hagit introduce our last presenter for today. And the questions could be regarding this topic. Please keep the questions regarding this topic added to the Q&A board.
Thank you. It is our pleasure to introduce Dr. Fabio Zaina, a leading specialist in physical and rehabilitation medicine with extensive expertise in scoliosis management. Dr. Zaina earned his PhD with a thesis focused on adult scoliosis and has been working since 2006 at ISICO, the Italian Scientific Spine Institute in Milan, where he concentrates on evidence-based conservative treatment of spinal disorders. He is deeply engaged in research and academic leadership. He serves as associate editor of the European Journal of Physical and Rehabilitation Medicine and has collaborated academically with Harvard Medical School, where he has been site director of the SOSOD group for the Principles and Practice of Clinical Research course. Dr. Zaina has authored 170 PubMed indexed publications and has received multiple SOSOD awards recognizing outstanding research contributions. A past president of SOSOD, he remained an active and influential voice in the international spine societies. His work has been instrumental in strengthening the scientific foundation of conservative care. Please welcome Dr. Fabio Zaina.
Thank you, Andrea. Thank you, Hagit, and welcome everybody. I'm very happy to be here with you today and with this special panel of experts. It's my pleasure to talk a little bit about one of the things we've been working on more recently, both on the clinical and the research side, which is aerial bracing, which is something very, very common in the world, but not so much focused on in terms of research. I have nothing to disclose about this presentation. So speaking about adult scoliosis, we had already a big introduction and a very interesting presentation by Dr. Castelein. We are talking about the three-dimensional deformity, which is a very frequent spinal problem in the general population. The symptomatology is quite variable, with some patient doing really well and other with really impaired quality of life. And the very specific problem of this population is the sagittal imbalance. I refer to the AB classification for adult scoliosis. AB refers to three different types of scoliosis. Type 1, which is the primary degenerative scoliosis or de novo, which is usually lumbar and thoracolumbar and connected to some degeneration, as already said, in the lumbar area. Could be the disc or the facet joints. And this is highly connected with pain and disability and frequently very, very fast in its progression. We have then type 2, which is idiopathic scoliosis. So the curves in this case can be thoracic, lumbar, double curves. Usually it's combined with a secondary degeneration of imbalance. It can achieve much larger curves, and again, it can lead to a very impaired balance of the spine, especially in the sagittal plane, and it can cause significant symptomatology in some patients. And then we have type 3, which are secondary adult curves due to an oblique pelvis connected to a length discrepancy, secondary curves in idiopathic, neuromuscular, or congenital scoliosis, asymmetrical anomalies of the lumbosacral joints, and then type 3B, which are the metabolic bone diseases, mostly osteoporosis. So this framework is interesting to categorize a little bit better our patients, also because the prognosis and what we can expect, it's different in the different types of scoliosis. About what happens during adulthood, we have an interesting study, which is a long-term study, the Iowa cohort, published by Weisland and colleagues over the years, with data about curve progression over 40 years and quality of life over 50 years. First of all, about life expectation, we know that the life expectation is the same in patients with scoliosis compared to the general population. So scoliosis is not life-threatening, and this is very important to keep in mind when we approach our patients. We know that can be some impairment of the breathing and the lungs, and this is true especially for curves larger than 50, 60 degrees affecting the thoracic area, and especially if there is a reduction on the anteroposterior diameter of the thorax, so less space for the lungs. About heart diseases, in idiopathic scoliosis or degenerative, usually no problems. We can have problems with secondary scoliosis reaching 100 or 120 degrees or more in the thoracic area. One of the big issues is the progressive collapse of the spine and the forward bending of the spine, which requires which causes more fatigue, more energy expenditure for the muscles to keep the spine straight and balanced, and the compensation of the hips. And according to the pelvis, big pelvis, small pelvis in terms of pelvic incidence, we can have more possibility to keep a balanced body or less, and so this postural collapse can be reached before or after, according to the case. Very important, the risk of progression for curves during adulthood. We know that for curves below 30 degrees, usually there is not a high risk of progression, even if we have seen and we see every day, even curves, smaller curves, that sometimes they progress because the exceptions can exist. But the risk of progression is more significant for curves larger than 30 and especially larger than 50. So the biggest the curve, the larger the curve, the higher the risk of progression. And these data are also consistent with the data by Edgar and Minmeta from the late 80s. On the left, you see single cursor risk of progression. You see the thoracic seems to be more at risk of progression in terms of speed. On the right, the graph is showing the behavior of the thoracic and lumbar components of double major curves. We have other data also from France, and this is very interesting because we have data about idiopathic scoliosis and degenerative curves. Type A in this graph are basically the idiopathic scoliosis, type B are the degenerative. You can see that the trajectories are quite different. Idiopathic scoliosis are slower in their progression in the most of the cases, while degenerative de novo scoliosis are more fast in their progression. And also the clinical impact is different because the degenerative are more, are impairing more the quality of life in many, many cases. About the results, this was about the natural history of scoliosis or untreated scoliosis, but we know that the mechanical point is still there also in treated patients. And basically what makes the difference, it seems to be the entity, the size of the curve at the end of treatment. So for curves larger than 45, these data are from Norway, you have a higher risk of progression over time. If you stay below 30, you have less. So it seems that whatever it is, treated or untreated, the size of the curve at the beginning of adulthood makes a difference. And then another very important point is the point about pain. We know that scoliosis can be more painful. Usually it's a very specific pain, even if patients can have also a common non-specific chronic back pain. We know something about the pain localization from a systematic review. In scoliosis, usually the pain is more asymmetric, and in case it's radiating, is more frequently radiating in the frontal area of the thigh. While for non-specific chronic back pain, it's more symmetric, bilateral in the lower area of the back, and the radiation is more posterior, usually to the thigh and to the leg too. And we know also that patients with scoliosis more frequently need to change position, can have limitation in sitting and standing if it's prolonged. They experience also limitation in lifting and in travels. So being this the general picture and the general problem, what do we know about the conservative? Because we know that for somebody, surgery is a very good solution, but not for everybody. We have, for example, the elderly can have a really high risks in case of surgery. We have patients who are not willing to be operated. There are problems connected to the cost. So we need to provide also alternatives. It's not just about surgery, of course. We know that specific scoliosis exercises can provide a reduction of the speed of progression of scoliosis and can improve also quality of life and pain. About bracing, which is a big part of this presentation, a systematic review dating back a few years ago, we have seen that there was not so much about bracing, despite the fact that many people around the world are doing bracing for adults with scoliosis, not just for kids. But there were just few studies in these systematic reviews, different outcomes, different duration of treatment. So very difficult to put data together and to understand and have a general picture. The general picture was that we know not so much about bracing in adults. So I want to give you a little bit of perspective from our experience and the experience from other teams we've been in touch with. And the one very interesting paper comes from Clemence Palazzo. It's a retrospective study. And in the group, they use these braces. They are custom made. They are not aggressive. They are quite soft. They just try to keep the posture and the alignment of the back. They are used few hours during the day. And they have found that with this kind of brace, you can slow down the progression both of degenerative scoliosis and idiopathic scoliosis during adulthood in a very significant way. In terms of single patients, you see that there were some responding better, other less, but there was a general very positive effect with this kind of bracing. We tried to use different tools in our experience. We used the PIC brace, now called the 3-point system, from an American company. And with this brace, we studied 20 patients with back pain and impairment of the quality of life. What I found is that in 1 month, you can improve significantly the quality of the pain in these patients, but you can achieve big changes in terms of quality of life. Maybe the dosage, which was just 2 to 4 hours per day, maybe the duration of treatment, we don't know. But improvement in the pain, not so much in quality of life, not statistically significant. After that, we produced another paper about nighttime bracing, applying custom-made braces, and we have found that we can achieve similar results in terms of pain with this kind of nighttime bracing compared to the off-the-shelf braces, the PIC brace. And this is very interesting because it's a totally different approach, and it helped us also to apply the braces also to younger patients that were not open, were braced during the day, or the brace were maybe too big for them, too evident that they were not willing to do that. So this is interesting, and now we are trying to use it more and more. This is the first case we braced. This is just 3 millimeters polyethylene custom-made brace, and thanks to this, we achieved important results on improving pain. We can see different versions because it's custom-made. So according to the body, we can achieve more or less correction of the posture. Some patients, especially the younger, are more balanced, others are less balanced. So this is the results. And it is well received and well used so far. You can see some of the X-rays of these patients. I mean, there are big curves, about 50, 45, 50 degrees or more. We have started also doing some in-brace X-rays to understand what's the potential for correction, realignment of the spine when they wear the brace. We will see in the future the results in terms of stopping the progression or improving a little bit the alignment of the spine. We will see. For now, we are just trying to restore the lordosis as much as possible and rebalance the trunk over the pelvis. There are other tools. This is another Italian brace called BJM1, and this is a very interesting tool working on different principles. It's very effective, especially when there is a forward bending of the trunk. And just to finish, I want to show you a clinical case of a patient that used a mixed approach. This lady, which was about 63 when she started with us, with a severe scoliosis, had a progressive collapse of the spine, despite she was wearing a full-time nighttime brace and doing the exercises. At the beginning, the balance was not bad with the brace on, but despite the brace, she started collapsing more and more and more. So we shifted to a different brace, the BJM1, and we can improve significantly her general alignment. She's compensating on the legs, of course, but before she was not even able to do that. So at the end, now she can stand much more than before, and I can say she's happy because she's not the kind of person so open to be happy, but she's more, she feels better. And you can see also in the X-ray in the center and on the right side, the changes in the posture. He's using the compensation on the hips, of course, but we are doing something to help her to have a better quality of life and balance. So in conclusion, the patient management during adulthood is quite complex. It depends on age. You can use the full-time, the part-time, during the day, during the night. We are still working on understanding which is the best protocol for each single patient. And we are very open to explore with patients and follow their feelings and customize the treatment much more than with kids, where we have protocols that we know that work, and so we are more strong in guiding them. It's very important, the sagittal balance and the coronal balance, so we have to keep them in mind, the both of them, according to the single case. The rigidity is a big issue, unfortunately, but there are some patients that are very old, very rigid, very unbalanced, and so it's worth trying even with the brace, because otherwise we have nothing for them. The autonomy can increase largely with the brace, and this is one of the goals. About the progression, we are still at the beginning of the journey to try to understand this. And finally, the acceptability, which is a key factor. We always discuss with patients to understand if they are prone to use this kind of approach or not. And the final decision is always of the patients, because it's their life and their quality of life. And thank you very much. It's all from my side.
Thank you very much, Fabio, for this very detailed presentation on the adult scoliosis. And I wish most of you asking the questions not by email, but in a Q&A board. We have questions by email. I will read them up in a minute. And thank you, Rene, finding the Q&A board and answering nonstop for all the questions regarding the disc and all the questions regarding not exactly this topic today. So we have a first question here, and I'm going to ask everybody to turn on their cameras, and all the panelists will be able to answer a short answer for the same question. We have, let's see if everybody is here now. Good. We have the first question, and we're going to ask one by one. Rene, maybe you're missing your camera still.
Andrea, I think you may have turned it off. I cannot turn it on because it says that the host.
Yeah, let me see.
Yeah.
Okay, perfect. Yeah. So welcome everybody.
Here we
And
are.
thank you very much for everybody's input in a different age group and a whole problematic condition in terms of scoliosis and management. The first question is regarding when to brace a teenager in terms of a cup angle. We're going to start from the beginning. An example, at 10 years old with a 22 cup degrees curvature, what would be your approach? And we're going to go for Rene first, and then we're going to go for everybody after.
Thank you. I would always brace that. 10-year-old immature. I say always, but there's one important thing to mention. Not all curves that we see are idiopathic scoliosis. And I think we, as more or less experienced people with some experience in treating scoliosis, we should be able, in most cases, to see that something is really an idiopathic scoliosis. And if this looks like an idiopathic scoliosis, it has all the characteristics, standard appearance of the patient, 10 years old, I would always brace.
Thank you. And maybe we'll add that with the normal MRI. Jean-Claude, what would you suggest for a 10-year-old patient with the 22 cup degrees?
Yes, very important, because between 10 and 11 years, we have sometimes a great progression. So first, I look at the ossification, the vertebral ossification from Hassan and Farman orthodontic classification. You look at C3, and if you have a deformation of C3 is not rectangular, then I use the night brace, because as Rene say, under 11 years, we can, with hypercorrective night brace, we can push the nucleus from the convexity to the midline. And this is very important, not so impugnative for the patient. So surely hypercorrective bracing, night hypercorrective bracing, if I have the deformation of C3.
Thank you very much. And let's go to Fabio next, Dr. Fabio Zaina.
Yes, I like very much the point of Rene. I must say that today I'm not at the level to be so, deep in the possibility to differentiate so much And so for now, I try to treat more based on the general deformity and the risk of progression in the short time that we have, short and long time. So basically, not just looking at the cobangle, but bone age, the growth phase. Is she growing a lot or not? The angle of trunk rotation is very useful. And the sagittal profile, do we have a flat back and alteration of the back of the sagittal profile, or do we have more, a postural scoliosis with maybe increased kyphosis and lordosis because she's very collapsed? So in that case, more exercises and less bracing. So I try to use the clinical information to guide my choice. And then, of course, the discussion with the patients because and the family, because it's quite borderline.
Thank you. And Dr. Alanay?
Yeah, I think for me, the magnitude of the curve is maybe with the second importance. So if I see any rotational change, which shows the curve is becoming structural, then if the patient has any growth potential, actually, I don't wait until the curve reaches to 20 degrees. So even for curve magnitudes less than 20 degrees, if I see rotation, I start bracing. Maybe in the beginning, nighttime bracing and just follow the patient and starting the exercises. But I believe, and the literature has shown that, as early as the braces started, so we have more successful results. So that's my philosophy.
Thank you very much. The next case is going to be a more mature patient. I know in Europe, Riser and North American Riser is a little different. So let's take a Riser 3.5, almost 4, with a 44-degree cobangle. What would be your recommendation? Let's start with Dr. Castelein again.
So 44 degrees width or 3 plus.
Mm-hmm.
Yeah, that's a difficult one. I think if you would end your growing period, whenever that ends, with a curve in the 40s, there's a big chance of progression. So the patients should know that. So the discussion will be continue bracing to give them a number more years with a flexible spine, knowing that the chance of further progression is real. Or if the patient would object to the appearance or other arguments, I would not even be against surgery. And then I think, but that's Ahmet's topic, tethering, well, Riser 3, well, you showed, Ahmet, that could be tethered also. So tether is a serious option for me also.
Thank you. Let's continue with Dr. Alanay, just to continue the thoughts on that.
Yeah. So as I mentioned in my talk, after I started my practice with VBT, Riser is no longer valid for me. So I don't really rely on Riser. So I need to see at least the Sanders classification and also the CVM. Then if Sanders 3, the Riser 3, which might be sometimes Sanders 3 or CVM 4, then it's a 40-45 degree curve is a big dilemma for me because, as Rene has stated, VBT may be an option. And then in that case, I discussed with the patient about VBT because that's the very narrow window period, especially for the thoracic curve. Because if the patient is more mature than Riser 4 and over, then I do selective fusion. But if Riser 3 and Sanders 3 with a growth potential or CVM 4, then VBT is something that I should discuss with the patient. And this is confusing the patient even more. But if the patient doesn't really accept to, go with VBT, then it's a very borderline magnitude for me. I think my decision would also depend on, whether it's a school time or not a school time. And if the patient is really very flexible with hypermobility, and if the patient is really want to go with bracing, with conservative management, I think it's still a good candidate for bracing, at least for a try under close observation. Then if I cannot really stop the curve progression, then I can go with fusion.
Thank you very much. And we're going to move on to more conservative care. Dr. Jean-Claude Mauroy, what would you suggest to this almost mature patient, the important scoliosis?
I see only patients who don't want surgery. So the indication
Me too.
is conservative treatment. But what is interesting are the results on the register, the results from Chicago. And for scoliosis, more than research 2 and more than 40 degrees, we have the possibility to avoid surgery in 90% of cases. Only 10% the treatment fail and it's necessary to make surgery. So there is a possibility with conservative treatment.
Thank you very much. And Dr. Zaina, what would you suggest for this almost mature patient?
Yes, also for me, they usually come to us asking for something which is not surgery. And I have no doubt to give a try with a full-time brace. And what I can tell the patient is that in 5 months, I can tell them what can be more or less the final result of the treatment. Because we have published that our 5-6 month results, especially in a patient as mature as this, is very, very predictive of the final result of the end of treatment in case they do the treatment in the proper way. So in 6 months, they can have an outcome and then they can decide they are happy with the result of the bracing, they can go on, they are not happy, they can go for surgery. But I think we have very, very high probability at least to stabilize for the moment, but we have good chances also to improve. In our statistics, we have an average improvement of 8-10 degrees. It's average, somebody doesn't improve, and we have 3% of patients who improve 20 degrees. So if this patient is the one in the 3%, that would mean to end the treatment around 25, which would be wonderful. Maybe she's not, but it's worth to try. You never know before.
Yes. And it's probably very important to check the rigidity of these patients and the curvature. The next case will be let's say 55-year-old female with frontal and sagittal plane imbalance and a 3D listhesis with some pain, minimum pain, very active. What would you suggest for this patient? We can start with Dr. Castelein.
So 55 or somewhere in that ballpark, and not much pain, but she had a rotatory subluxation?
Rotatory subluxation as well as frontal plane and sagittal plane imbalance.
But not many complaints?
No.
And active?
Yeah, not yet.
I don't think I'd do anything. I just let her lead her life.
Okay, thank you. Dr. Alanay?
Yeah, I think it's the same for me because, we are doing a surgery to improve the quality of life. So her ODI is not really very high, something like 60 or over 50. Then I think I would just observe and start physical therapy to strengthen, the muscles and just observe him.
Thank you. And Dr. Jean-Claude?
Yes, we have in Lyon 150 adult hard brace. We use a version of the hard brace. The idea is with a metallic bar to maintain the sagittal plane. So this is the advantage of the Lion system. And we use polyamide 3 millimeter laterally to let some mobility in the frontal plane. And the treatment is for 6 months, 3 weeks full time, and then 4-6 hours every day, and during 6 months. And usually we fix the instability.
Thank you very much. And let's move on to Dr. Zaina.
I'm not sure about the age. I didn't understand the age of this patient.
It's 55 years old, female with the frontal plane,
55 years.
yeah, post-menarche, rotatory dislocation, frontal plane and sagittal plane imbalance, still active but progressing.
Yes. So, of course, I discuss about the surgical option to understand what she's thinking, if she's thinking about that or not. If she's not interested in that, for sure, I would start with exercises and we can discuss eventually nighttime bracing, for example. And again, to tell her that in this case, in adults, to understand the outcome, I think I need at least a couple of years to understand if we can do something to change. Because if just in few months you cannot understand if you achieve real stability or a couple of degrees of change in the X-rays doesn't mean anything. You need longer follow-up time. But I always speak clear about the option of surgery because I want them to be very committed to their choice and not in a way that they don't miss the window for surgery in case they want to do that. I want them to decide with all the information and eventually speak with the surgeon.
As a second opinion, that's a good suggestion. Now let's jump into older age group. We have two more questions. One for an 80-year-old patient who has severe scoliosis all her life and now is not a candidate for surgery, but progressing with severe pain. What would be your approach? Is there any option to halt any further progression for an 80-year-old patient? So let's
For
go
me,
to Rene. Do you see very old patients, Rene?
Me?
Yeah.
Yes, I
Okay.
see them. Well, that's a very difficult situation, almost no-win situation. And I think you say she cannot have surgery. Well, there are 80 years old patients that can certainly have surgery, but if you say she cannot, so there must be severe comorbidity. So that means, first of all, I'm not a big fan of these extensive surgeries. I think they really lead to a lot of morbidity, although they have been shown to improve the quality of life, of course. So surgery is an option unless the patient cannot survive a big surgery. So then what you have is symptomatic treatment. And that goes from exercises to strengthen muscles, which is not easy at the age of 80, to improve posture, to bracing. Bracing would certainly have a place in my mind. And then also the pain doctors trying to alleviate pain from maybe impinged nerve roots and things like that. So that's a big analysis, but exercises, pain medication, brace, pain doctor.
Thank you very much. And Dr. Alanay?
Well, I think this is a very general question, Andrea. So it
No,
depends on what kind of 80 years old patient. If very healthy, active, and with not too much comorbidities, if the quality of life is really very bad and non-responsive to any conservative management, including injections and everything, we consider actually surgery. It depends on, how big surgery. Is it something that I can do locally or a T2 to sacrum fusion? So there are too many, variables to answer this question. But 80 years doesn't mean we don't do surgeries. Yeah.
Thank you. Thank you. And Jean-Claude, what would you suggest for this patient?
Yes, first I will try if there is a reducibility. This means that lying, the head must touch the examination table, and the same in the frontal plane. I control that she is able to maintain a straight line on the gravity. Second, if there is a reductibility, I lift the patient under the shoulder and I ask her if pain is better, if there is a release of pain. If yes, I try to make a brace. But reducibility and release of pain with lifting under the shoulder.
Thank you. Dr. Zaina?
Yes, for me, so first, try to understand, like my colleague said, what kind of patient it is. And for example, if she's able to do exercises or not, if she can follow. So that is part of the treatment for sure. And then I think in that case, a brace would be very helpful. And I would discuss with the patient the strategy. If something during the night, something during the day, something during the night, and some hours during the day, I try to customize very much the treatment. And also in terms of building the brace, it depends a lot on the flexibility, as Jean-Claude was saying, because I brace also rigid patients if there's no other option. It's more challenging, but I do that anyway. What you can achieve is totally different. But you have to do something to try to improve the quality of life of this patient. So you discuss, you try, and then it depends on the basic condition.
Thank you very much for all of you. As today we are concluding this gray zone discussion, we know that gray zone will exist and will continue to exist in surgical and conservative care as well. This type of discussions and information is extremely helpful for our practitioners around the world. And these conversations are very important to unite the knowledge and try to treat the patient the best we can. Clearly, everybody has an individual assessment and individual goals discussed with the patient, and it is very important to have the patient come with an educated consent for the treatment options presented for them. If you have a question and you haven't had the question answered, you can email us at ssoaglobal@gmail.com. We can connect you with the specific presenter regarding your topic and questions. And please visit the SSO library. There are lots of discussions and presentations there regarding activities, regarding early onset scoliosis, regarding all the different topics you're bringing up in a Q&A board. So please further educate yourself in the topic you're interested in. And I really want to thank you all for taking the time to come into SSOL to present today and lecture us and give us more perspective of all your experiences combined over 100, 200 years of experience here. So it's really important for us to continue these discussions as we reach and teach around the globe. Our next segment is going to be March 28. We have a literature review every 2 months with Dr. Jean-Claude to keep up the education. All the SSO members are allowed to participate in that. And keep checking into the future webinars, and we hope to have you all back again, as you have been very consistently coming back, as we need to learn more about your expertise. And I wish everybody have a great weekend, hopefully warmer than us, and enjoy it with your family. So thank you so much for every one of you to join us today.
Thank you.
Thank you
Thank
very
you.
much.
Bye.
Thank
Have
you.
a good night,
Bye-bye. Have a
everyone.
nice
Okay.
evening, everyone.
Have a nice day.
Bye-bye.
Okay.
Thank
Bye-bye.
you.
Great to see you all.